as a junior and then a senior in high school, I had the opportunity to shadow different physicians and then health careers as a high school student. So I shadowed orthopedic surgery. My best friend became an orthopedic surgeon. Shadowed ENT. One of my other best friends is an otolaryngologist or ENT out east. And then I liked ophthalmology. So one of the first surgeries I watched was cataract surgery. It was pretty amazing because then the next day after the surgery, I got to see these patients. And again, I appreciate it a little bit differently now, but patients would, come in with these terrible cataracts and be kind of, disabled from not being able to see well. And then the next day they're seeing fantastic and smiling. As opposed to, some other different types of surgeries where there's a little bit more healing. One of the big things that drew me to ophthalmology initially was just kind of the pace of surgery, the patient experience, the volume. And after having LASIK myself, done by one of my partners, I can see how much more I appreciate just getting up in the morning and being able to see. From there, once there was kind of a motivation or inclination to do ophthalmology, and in undergrad I did research, and then in medical school did retina research, where we took skin biopsies from patients and then made stem cells out of them out of patients that had rare diseases, and then from there attempted to fix the problem or recreate their retina in a dish to then eventually be transplanted. And that was all at the University of Iowa with Dr. Bud Tucker and Dr. Ed Stone. So that was pretty fascinating. So then I got drawn to the actual research part, and then kind of coming full circle once I was kind of getting in the later years of medical school and back in the OR, I was like, okay, I really like the surgery, decided to pursue ophthalmology, did a residency, and then liked the high volume, the pace, the efficiency, and the patient satisfaction. Initially, I liked the volume and the pathology and the rare diseases that I got to see in residency. I don't see as many rare diseases as I did in residency, which is fine. but now, more than anything, I like seeing my regular patients seeing. Most of them ask me how my kids are doing, want pictures of my kids, ask how they're doing. I get to know them, their families, and get to watch them progress in life. And I appreciate that more now than I think I initially did coming out of residency and being younger. But I think the other thing is, again, I see patients that, I see their cataracts progress on an anecdotal level, and then I take care of them. And from then I can see in their chart, when I did the surgery, and they're seeing better. And I know, from the moment that they had their cataract surgery, that they're going to see better for life. So have a small little part in getting them seeing better and making their life better. Some of the most frequent eye diseases or problems, complications, issues that I see being a comprehensive practice would be macular degeneration, glaucoma, cataracts, and diabetic retinopathy. I would say those for a comprehensive practice are the most common things. Also, some of the most treatable problems. So to me, again, my partner, Dr. Arkfeld, usually treats the diabetic retinopathy when it's indicated, when it becomes a problem. So we all, I think, as comprehensive ophthalmologists, look at all different pathologies, but then treat specific disorders. So we all see those main ailments, like I was stating, glaucoma, cataracts, macular degeneration. But the ones that I typically see would be glaucoma and cataracts. And the main reason for that is because I do cataract surgery, and at the same time I can do what's called minimally invasive glaucoma surgery, or MIGS, so that at the same time as cataract surgery, I can insert some small stents or do other procedures at the same time as cataract surgery to not only get a patient seeing better, but to lower their pressure to potentially get them off drops. So I typically see, again, cataract and glaucoma patients, while I certainly see just regular comprehensive eye exams, family members, eyelid issues, and do eyelid surgery. So I would say the most common would be, again, though, cataracts and glaucoma. So I approach individualized care or patient care in a unique, I think, setting. It's a little bit different than other specialties. We have the ability to get tests on all of our patients, which we have, I think, cutting edge, the most advanced technology in our office that's available to address specific needs for every patient according to whatever timeline or age they are. So for young kids, we're able to correct or slow down myopia or nearsightedness to prevent them from having a statistically increased risk of a retinal tear while growing up. So that would be one thing that we have the ability to treat in our office and monitor with all of our testing. So using advanced technology to monitor that and treat it. For patients that get a little bit older, we're able to correct their vision using, again, our state-of-the-art equipment to correct astigmatism, to change the prescription. LASIK is one of those options. We have a whole ton of other procedures, intraocular contact lenses or ICLs as another option to, again, correct people's vision. As far as viewing the retina following glaucoma, we utilize technology, in my opinion, the best, not only using technology, but as far as using that technology to then individualize care based on pressure goals for a glaucoma patient or treatment options for a patient with macular degeneration. So utilizing advanced technology, we're able to individualize that care specific to each particular ailment and across all age ranges. So the biggest recommendation that I would have to maintain good eye health, number one, and this goes without saying because you hear it everywhere, is to not smoke. Smoking is certainly a precursor to poor health, but also worsening health, which I think that's something that doesn't necessarily get parsed out. We think of smoking as kind of being an acute problem, but over the long haul, smoking, as a build-up effect of poor health that I've seen, with patients, family members, things like that. The other thing, again, is eating right, exercising. All those things are very obvious choices, but also preventative care such as regular eye exams, particular ophthalmology, but also seeing your primary care provider to take care of high blood pressure, diabetes, things like that, because those things have secondary effects on not just your eyes, but also kidneys and other body organ systems that can, again, have a cumulative effect to causing poor life. The main points I think that patients should keep in mind as far as continuing a longevity of good vision, but also good overall health would be, again, eat right, exercise, not smoking, and again, taking those preventative health measures to get checked and take care of problems or small issues before they become larger issues. In Omaha, it's also obviously a large city with a small town feel. I think is a very typical Midwest feeling. So I do enjoy staying in the Midwest and staying with people that know how I grew up, even though it is from Iowa. I am from Iowa and went to the University of Iowa. Again, I think that I appreciate the small town feel that, again, Omaha has. And again, I see patients kind of all over and have connections, whether it be business-wise, professional, personal, neighborhood. And again, that's something I think unique to our practice in Omaha also.